name is Carolyn Rodriguez, and I'm an assistant professor here in the Department of Psychiatry and Behavioral Sciences at Stanford. I'm also the director of the Translational Therapeutics Lab. And the mission of our group is really to develop and identify rapid-acting treatments for obsessive-compulsive and related disorders. And it's my pleasure to talk to you today about the question, when does an obsession become a disorder? So I'll begin by defining what is an obsession. An obsession is a thought that continually preoccupies or intrudes on our minds. Now, all of us have thoughts that are intrusive, that cause us anxiety. One is, did I remember to turn off the stove? Or if you're flying somewhere, did I remember my cell phone charger? Now, these kinds of intrusive thoughts then transition to obsessive-compulsive disorder when they happen more than an hour a day, and they cause impairments in functioning. This can be in a lot of different domains, like the ability to form relationships or to work or go to school. Another thought that can be intrusive on the mind is a thought about particular objects that cause you pleasure, things that you find aesthetically beautiful. All of us have an attachment to items, but these things can transition, these thoughts can transition into hoarding disorder when this attachment to objects then results in the volume of possessions being so great in the home that they interfere with the ability to function in the rooms of the home like you normally would. For example, sleeping on your bed or cooking in the kitchen. Okay? And this transition also occurs with impairment in functioning, again, inability to form relationships, school, and work. So today, we're going to explore these concepts together. I'm going to tell you some stories about the research that I've been doing and continue to challenge you with some thought experiments throughout. I'm also going to talk for about 30 minutes. Go ahead and join us in the front. And then I encourage you to take down any questions you have during the talk so that then we can have a fruitful discussion afterward, and we'll have plenty of time for that. Okay? So the first thought experiment is that I want you to imagine that you are on a long hike, and you've been in the desert for hours and hours and hours. You're parched. You realize you forgot your canteen, and you just really, really want to drink. But the only water lies in a toilet bowl. Okay, so think to yourself, would you drink this water? Okay, and I'm going to ask you for a show of hands in 3 categories. First is, of course, I would drink right away. The second is, I'm not exactly sure, I'm having a lot of thoughts here, but ultimately you would drink. And the third category, absolutely, no way, I would absolutely not drink this water. Okay? So, show of hands, who would drink right away? Oh, good. Okay, good. I see a few hands come up. Second category, how many would maybe take a little time, but might ultimately drink? Wow, that's a lot of you. Okay. And how many people would absolutely not drink from that water? Okay, we're in solidarity. There's a few of us out there. Thank you. For those people who were in the middle category and had that pause, if you would be so brave to just call out, what were the things that, what were the thoughts that prevented you from drinking the water right away?
Is it healthy?
Is it healthy? Yes, what's in that water? That is a thought. Anything else?
Well, I kind of did a calculation, when is
Yeah.
the next water going to appear? If there was no alternative, or if I thought it was unlikely, then...
And why wait? Why delay? Why not drink that water right away? Okay, there may be some contamination. We don't know exactly what's in there, right? Okay, and so I wanted you to just think through, because an individual with obsessive-compulsive disorder who has intrusive thoughts about contamination, to them, drinking just from a normal water fountain may feel like drinking from a toilet. Okay? And those little pauses that you had, calculations and thinking about when's my next drink, somebody with OCD with contamination, that happens to them all the time. When they're out and about, they need to be making that calculation that you made all the time. They need to bring water with them. And as you can see quickly, if you're having this thought about everything that you're touching and your environment, it can greatly disrupt your relationships. It can greatly disrupt your ability to work and function in the world. So the hallmarks of obsessive-compulsive disorder are obsessions. These are these intrusive thoughts that increase anxiety, and accompanied with compulsions, which are repetitive behaviors that individuals have to do for them to feel that the anxiety is coming down. Obsessive-compulsive disorder is very common. It has a 2% lifetime prevalence. And many people, you hear in the media a lot, oh, it's a personality quirk, right? But in fact, 1 in 7 adults with OCD will attempt suicide in their lifetime. It's very serious. And what makes it even more impairing is that individuals can start having OCD early in their life, which can disrupt their trajectory. And half of cases start by age 19. We have treatments. The only FDA-approved medication is serotonin reuptake inhibitors. These are medications that block the resorption of serotonin, which is a chemical messenger, and increases the ability for that messenger to have the nerve cells talk to each other. There's also a very effective treatment called cognitive behavior therapy with exposure and response prevention. And this therapy helps individuals break that association between an obsession of worries about contamination and then the compulsion where they have to repeatedly hand wash or wash in a ritualistic way. And the therapy involves making a hierarchy and exposing individuals to different rungs of the ladder, from least anxiety-provoking to touching a desk to most anxiety-provoking of putting their hand in a toilet. And the therapy works by showing them that they don't have to do the repetitive behaviors, and anxiety will come down naturally on its own. Now, there's a lot of promise with these two first-line treatments. About half of individuals will get better with these treatments alone. However, there's still another half of individuals that need treatment, and that's where my research comes in, to try and help those individuals. As well, these types of treatments can take a long time. It takes around 2 to 3 months for there to be clinically meaningful improvement in one's symptoms. And I'm very passionate about trying to find effective treatments that work rapidly. Now, obsessive-compulsive disorder, like many of the mental health disorders, are increasingly thought of as brain circuits gone awry. And in OCD, there's a thought control circuit that's thought to go awry, which is comprised of an area here, which is the orbitofrontal cortex, that is important for decision making, looping to the striatum, which is important for motor function, and then looping through to the thalamus, which is a relay station back to the orbitofrontal cortex. And we know the circuit is hyperactive in OCD. And the hyperactivity may be due to abnormalities in serotonin, the neurochemical that we just talked about, and an excitatory neurotransmitter called glutamate. And there's increasing evidence that abnormalities in glutamate may play a role in OCD. Now, behaviors such as the ones that I talked about in OCD, like this compulsive hand washing, is comprised, the behaviors that we have are comprised of consequences of different levels, right? There's at the receptor level, this is the docking port for serotonin and glutamate. These nerve cells form building blocks to create circuits. And then those create, the circuits together create neural networks. And so you can use what we know about neuroscience in order to be able to understand more about the disorder by exploring these different areas. I started my research by examining at the molecular level. and very interested in glutamate abnormalities in OCD, I wanted to identify a drug that may act on this receptor to see if it could rapidly decrease OCD symptoms. Now, at the time when I was starting this line of research, I came across a medication called ketamine, which is at high doses used routinely for anesthesia in adults and children, and at very low doses had been shown to cause rapid decrease in depressive symptoms. And I thought to myself, that's very interesting. Is this something that could help individuals with OCD? At the same time, I was very cautious because ketamine is also known as Special K. It's a drug of abuse. And so I wanted to be very cautious about what we were planning on doing. Why did I think ketamine for OCD may have promise? So there is, at the time where I was reading more about ketamine, I came across a paper about a protein that's important as a scaffolding for the glutamate receptor, the docking port for glutamate. And when researchers, Welsh et al., disrupted this protein, they found, in animal models, they found that these animals repetitively groomed themselves to the point where they had bald patches. They also had increased anxiety. And what's interesting is that when these researchers then added back the protein in the striatum, one of the regions of the thought control circuit, these repetitive behaviors went away. So the hypothesis then was to test this in individuals with obsessive-compulsive disorder. And in collaboration with Helen Blair Simpson at Columbia, I designed a study in which we were able to test with ketamine, which is a glutamate receptor blocker, whether the symptoms of OCD would decrease. And what we found was indeed the OCD symptoms rapidly decreased. And the way we did this experiment was that we randomized 15 individuals to either get ketamine or placebo. And we asked individuals over time to rate their symptoms, their intrusive obsessive thoughts on a scale of 0 to 10, 10 being constant intrusive obsessions and 0 being none. And we asked them to rate it before a 40-minute IV infusion of ketamine or placebo, and then to continue to rate their symptoms that same day and then several days after. And what we found was, in the very beginning, before the infusion, everybody had these intrusive thoughts. And then, over time, midway through the infusion, there was a clinically meaningful difference in terms of the symptom reduction. And what's interesting about this is two things. One is that this decrease persisted past the time that it takes for ketamine to be metabolized and cleared out of the body. So the effects persisted. That was interesting. The second was that these individuals were not on any other medication. They were not taking serotonin-based medications, so we couldn't attribute it to the serotonin system. And in fact, since this is a medication thought to act through glutamate, it gave us more confidence about this hypothesis. So we also examined overall what are the symptoms of obsessions and compulsions like during the past week. This is using a scale called the Yale-Brown Obsessive-Compulsive Scale. And what we found was that the number of individuals that had a 35% reduction in this scale was 50% in the group of individuals with ketamine, so half of individuals, and 0 in those with saline. Now, I'm a clinician, and these numbers are great, but I wanted to really know from the patients, what was this like? And one of the things that they reported back was that they had side effects. Everybody had a feeling of dissociation and floating. 2 people were dizzy. 1 person had nausea and vomiting. And everybody had mild transient elevations in blood pressure and heart rate, which are consistent with what you would normally see with depression studies and giving ketamine to individuals in general. They also reported feeling, I feel as if the weight of OCD has been lifted. I want to feel this way forever. I don't have any intrusive thoughts. This is amazing, unbelievable, right out of a movie. And I tried to have OCD thoughts, but I couldn't. It's amazing. So in summary, this is the first study showing that ketamine can decrease intrusive thoughts in the absence of serotonin reuptake inhibitors, and that glutamate modulation may be a target for rapid-acting OCD drugs. The challenge is that the ketamine's mechanism is unknown. And we talked about ketamine acting through glutamate. Does it really? I'm a little bit of a skeptic. Can we really show this? And so I partnered with Dikoma Shungu at Cornell and Larry Kegelis at Columbia to use a technique called magnetic resonance spectroscopy. This allows us to look at the levels of glutamate and glutamine combined together to make a compound called an entity GLX, and an inhibitory molecule called GABA. And what we can do with this technique is we can set an area to examine these neurochemicals. And so we put it here in an area of the brain that is important in the thought control circuit. And the results were quite surprising, which is a wonderful thing about science. Any of you out there who are interested in careers in research, the glutamate did not change when we looked at baseline versus 1 hour post-infusion. In fact, we saw an increase in GABA, which is an inhibitory compound, which is then made me rethink the hypothesis. Is it possible now that GABA is actually inhibiting the hyperactivity of the OCD circuit? And that's really where the benefits of this treatment are coming from. So we have a current study to assess this question in a larger sample, so stay tuned. As well, what's interesting is we had a colleague who did the same experiment in individuals that had major depression. And what he discovered, Matthew Milak discovered, is that glutamate did go up and GABA did go up in that study. So in summary, this is the first study of the effects of ketamine on glutamate, glutamine, and GABA in OCD in this prefrontal cortex region. And also starting to get hints that ketamine may have a unique action in OCD compared to major depression. A challenge that I talked about again as a clinician is that ketamine has side effects. We wouldn't want this for our patients. And so I sought out to find a compound that could act the same way, a glutamate modulator compound, as ketamine, but wouldn't have those side effects. And what I found at a conference when I spoke with Dr. Joe Mascal was that he invented a compound at the time known as Glix-13 and now Rapastinel that had these properties in depression, in which it had these antidepressant effects but didn't have the side effects that I was seeing in ketamine. And so he generously donated the study drug. I got funding from a foundation, Brain and Behavior Research Foundation, in order to be able to fund a small pilot study to test this out. And what we found when we gave a single 3 to 5 minute IV infusion of Rapastinel at 10 milligrams per kilogram in 7 individuals that had at least moderate OCD, they were also drug-free. They were ages 18 to 55. And we excluded individuals with severe depression and psychosis, bipolar, and substance dependence, was that we saw again this very rapid decrease in obsessions, depression, and anxiety when we asked individuals to self-rate these symptoms on the day of the infusion. It came down at 90 minutes and persisted out to 230 minutes. Now, what was most motivating to me as a clinician is that the individuals did not have these side effects. So in summary, Rapastinel was well tolerated in drug-free OCD patients as it is in patients with depression in the small pilot study. Unlike ketamine, it did not have the side effects. We did not have anybody that had dissociation. Nobody had nausea. It was remarkably well tolerated. And it had acute effects on OCD, anxiety, and depression, which was very promising. However, with regard specifically to OCD, that 1 week out, we did not see anybody that had clinical response. So one of the next steps is looking to see if this is a drug that we would need to have repeated dosing. And this drug is now in phase 3 clinical trial and may be approved by the FDA for depression is the indication. So future directions for this work is what is the mechanism of ketamine's rapid action? That's a study that's ongoing right now. How can we predict who will get benefit? And if you live here in the Bay Area and you have OCD, please email us at ocdresearch@stanford.edu if you're interested in participating in research or would just like to get referrals, advice, connections to care. We really want to help the community here and beyond not suffer in silence and suffer alone. And we have a lot of different research studies going on, not only a ketamine study that's NIH funded, but we also have a study that's going to be launching soon of non-invasive brain stimulation that uses the brain's natural rhythm in order to be able to test rapid action of a treatment. We also have studies that involve cognitive learning. We have studies that involve therapy, cognitive, behavioral, and exposure and response prevention therapy. So we try and do it so that any kind of study that you may be interested in, you can join us for that. Now, we just spoke to you about obsessive-compulsive disorder. I'd like to move now into another type of thought that may preoccupy our minds, and that is an interest in our everyday objects. Now, some people have an appreciation for objects that goes beyond what we may know of. So, you know, we've all been in a grocery store and seen these typical Campbell's soup cans or other stores. How many times have you actually thought, oh, that's so beautiful. You know, I need to capture the essence of this. But in fact, Andy Warhol was an artist who felt so strongly about these soup cans that he actually created 32 different canvases of all the varieties of Campbell's soup. The Dada movement features these ready-mades, which are ordinary objects like a shovel or a bicycle wheel that are housed in modern art museums. And it really challenges our assumptions about what is art. Duchamp famously had a quote, which is, an ordinary object can be elevated to the dignity of a work of art by the mere choice of artist. What about collecting? So some people really have an affinity for the beauty of specific objects. And in fact, it's common, it's pleasurable. 30% of British adults in one survey engage in collecting behaviors. Now, this transitions then into hoarding disorder by the level of disorganization, right? So individuals that have an affinity for objects, who are collectors, just organize them, display them proudly. And it can be a little surprising to see something like this, right? It's not organized. There's items that are in the living room, in the kitchen, and the garage. And so individuals have both lack of organization and they're also quite embarrassed about this, as opposed to collectors, which are proud. Hoarding disorder is persistent difficulty parting with possessions. It results in impairment and clutter that disrupts functioning of the home. Distress and impairment, and it's not due to a medical condition. So if you break your arm and you have trouble clearing things out, that's not hoarding disorder. Similarly, it's not due to another mental disorder. So if you have schizophrenia and you're hearing voices that make you scared to go outside or take any of your trash or objects outside, then that is also not hoarding disorder. It's actually quite common amongst us. 2 to 6% of the population have difficulty with this. And it's a problem that actually extends beyond the individual, right? It's relevant to public health because it can increase the risk of fire. Sometimes people are looking for a place to store their items and will store newspapers inside of the oven. That's a fire risk. Also, there's destruction of property. The sheer weight of items can warp the floorboards. And it can be a health hazard in terms of tripping for the individual and pest infestations. So what is the challenge, here? It's the strength of attachment, okay? And that's so painful for family members and the individuals themselves. They say, why don't you help me? Why can't I help you? Really help you get rid of these things. And it's very difficult, The family members will say, let's help you. Let's help you recycle some of these items. Let's help you donate some of these items. So I'd like to do another thought experiment. Imagine I brought into your living room all of these beautiful ancient Egyptian artifacts. Just put them your whole living room is piled with these, okay? Now think through I came back a day later and I said, there's too many Egyptian treasures in here. We're going to recycle them, donate them. How would you feel? That'd be hard? That'd be hard, right? Right? And so to individuals that have this, these items that to other people may look like things that are not meaningful, not have a monetary value, actually are very, very valuable to them. So, as you can imagine, it's difficult to do this kind of work and do this kind of treatment. And so my first step into this line of research was to try and understand, what do individuals want? What would make people feel more comfortable for us to help them? And when we did a survey with 13 different available treatments and services in the community, what they found the most acceptable was individual cognitive behavioral therapy focused on hoarding disorder, things that were very personalized, like a professional organizer to come into the home and help them, and self-help books. And those aspects that made it more acceptable were personalizing of care, being held accountable, somebody who could help them track, and believing that these treatments were working. Also surprising is that the least acceptable included serotonin reuptake inhibitors, medications that may be helpful for hoarding disorder. They found them as acceptable as a forced clean out or a court-appointed guardian. So as a neuropsychopharmacologist, that was very humbling. We can design the perfect pill, but if an individual doesn't want to take it, we need to rethink our strategy here. So the aspects that were least acceptable were not having control over the process, anticipating distress or harm, and not believing that the treatment works. And so we took all of this feedback. We partnered with Randy Frost at Smith, who was the person who originally described this disorder, and Lee Schur and Beck Schur, who are peer supports with the mutual support services, to design a program that took advantage of these ideas for maximizing the impact, offering choice, accountability, and increasing that the treatment works. And so together we did a very small pilot study of 5 individuals with hoarding disorder, and we gave them 15 sessions of group cognitive behavioral therapy treatment, but that was grounded in a treatment called Buried in Treasures. And in addition to that treatment, which was done in a setting outside of the home, we also added 20 hours of home uncluttering to practice those skills that they were learning outside of the home and bring it inside of the home. And a talented postdoc in my lab, Omer Lenkovsky, analyzed this data and found some very promising results that I'd like to share with you. So first, I wanted to explain how we assess clutter in the home. That may be a question that you have. And this is something called a clutter image rating scale. It was designed by Randy Frost and others. And what it is, it's a scale of different rooms in the home. And here is a bedroom, but we also have one of a kitchen and other rooms of the home, on a scale of 1 to 9, with increasingly more levels of clutter. And with the intervention, we found that these 5 individuals on average were about a 5. So you can see in this picture that individuals, it was practically impossible to sleep on the bed, right? And through the treatment that we delivered, we actually were able to reduce the level of clutter in the short amount of time to a 3. So we're not at a 1, but this really provides inroads into now being able to access and function rooms in the home. And similarly, when we asked individuals to self-rate their symptoms over time, we found that overall there was a significant difference in 18 weeks. Now, this is very promising in terms of the time course and how we can help individuals. So next steps is to understand what happens in the brain. What is the neural basis of this attachment and the neural basis of the loss and the difficulty parting with possessions? We also encourage you, if you have clutter problems or have a family member who has clutter problems, please email us at clutterhelp@stanford.edu. We have an active study going on right now that is taking this concept, this pilot study, and doing it in a much larger group. Again, I'm a skeptic, and just because I'm seeing something in a small population doesn't mean that this is really the right direction we're going. We need bigger numbers in order to be able to be more definitive about our conclusions. I'd like to thank my lab, the members of the Rodriguez lab. They are really passionate and committed about these topics, and if you reach out to us, you'll be getting one of us on the phone or over email. I also want to thank, as you know, it takes a village to do this work, and I want to thank my additional collaborators listed here. I've said their names as I've gone along, but I also want to highlight it here. I also want to highlight my funding sources, which are the National Institutes of Mental Health, private donors who are just wanting to contribute to the science and the work we do, as well as foundations. I mentioned the Brain and Behavior Research Foundation. And ultimately, what we want to have is have an impact on our local community and beyond, and really demonstrate that rapid-acting treatments are possible. We want to shed light on the severity of mental illness and decrease stigma. And so, if helpful, some of these exercises and thought experiments are things that you can share with your loved ones to help them understand how painful these disorders are. And finally, we need you. We need research partners. We need individuals to participate in our research studies. We need students, we need collaborators, and we need funding to make these discoveries possible. We are excited and hopeful about the future. I think there's a lot of promise out there, and together we can really do great work together to advance science. So thank you very much. Great, and so now I'm open for questions, and so I'll just start in the inner ring and move out.
Is there any connection between OCD and hoarding disorder? I saw you have the same serotonin. And myself, I thought, I have a little bit of OCD. I also thought, I don't know whether there's any connection.
Okay, great. So I'll just repeat your question so everybody can hear, which is there any similarity, was your question, between obsessive-compulsive disorder and hoarding disorder? And how do you kind of distinguish that for individuals that may not identify with aspects of each of them? So just to back up a little bit, within our profession, there's something called the Diagnostic Manual of Disorders. And for a long time, hoarding disorder, these elements were thought to be part of OCD. And so it was diagnosed as part of obsessive-compulsive disorder. But as the research and the pace of research and our understanding has advanced, there's actually distinct underlying neurobiology between OCD and hoarding disorder. And as well, there's a lot of differences which I've tried to illustrate here that highlight there are a lot of differences. So individuals with obsessions have these intrusive thoughts and repetitive behaviors. Individuals with hoarding disorder, one of the most troubling aspects is letting go of items. So it's distinct, and it's not a coincidence that these things can be separate. But nature is not carved at its joints. Just because there's a manual that says that this is something doesn't mean that that there's elements of these things. And I myself find myself bombarded with email messages, phone calls, and mail. Like, we're in our society, we're getting a lot of information, and so I feel myself the pace of trying to process all of these things as quickly as possible, and I see piles accumulating, and it's a challenge. So it's a problem that I think, and a challenge that we all face in a continuum, and something that we can address together. Does that answer your question? Okay, great. So let's start in this ring, and then we'll keep going up.
Is this disorder hereditary? It runs in a family, or and what is the cause of it?
So the question was, what is the cause of the disorder, and does it run in families? And so we don't know what causes these disorders, and that's part of the research and why I'm motivated to do this, not only on the clinical side, but to really understand the brain basis. We do know some factors about it, but we don't know that part of it. The other is, absolutely, it does tend to run in families. And there hasn't been sort of a gene that has been identified that can be solely responsible for OCD or hoarding disorder. Genetic research is continuing in these fronts, but we do know it seems to run in families.
Okay, and just the last question, the attachment with the things. So we observe that more with the child when they are in the early age, they don't want to give away any of their toys and all that, but as they grow, that's fine. So is there any kind of relation there? How it's in the beginning of the life years, it's more, and then slowly it disappears.
Yes. So the question was, noticing that children have things that they collect. And in fact, I can't imagine, let's just do a little experiment here. We'll do a show of hands. How many of you had a collection of some sort as a child? Okay, great. So a lot of people have this collection, this desire and interest, but then not everybody continues that passion for collecting on. We don't know why that is, why some people then transition to hoarding disorder and some people don't. So it's a good question, an unknown question.
Okay, thank you.
Okay, so next, yep.
Thank you for your talk. It was fabulous. It was very informative.
Thank you.
But I'm curious about the the fact that it seems like the emotional part of our brain takes over the logical part of our brain. You can consider yourself a logical person, but yet when it comes to discarding stuff, there's that emotional tug
Exactly.
that interferes.
Exactly. So the point is that the question is that there is a thought control aspect to it, but a very important aspect is the emotion. And how do these different processes interact with each other? So just to take a step back, I highlighted the thought control circuit, but there is an emotional regulation circuit, and we're starting to investigate the interactions between these two things, because exactly as you pointed out, we can talk about letting go of an item, but then when you're in the moment, all the memories, about how important the object is, how beautiful it is, thoughts potentially, this can be useful. Why would we want to throw something like this away? It's so challenging and so difficult. And I really admire the bravery of individuals that participate in our hoarding disorder studies, because it takes a lot of courage to part with possessions, many of which are rich with history and meaning. And yet, too much of these items are really impacting in their lives. Okay, so next, yep.
Thank you for your presentation. In an effort to self-diagnose a disorder as opposed to normal thought, can you help me to differentiate or define what would be a good...
Exactly. Well, thank you for raising it. So what is the difference between just having these obsessive thoughts that pop into our mind, and when does it actually cross over into a disorder? So for obsessive-compulsive disorder, it's having these intrusive thoughts that you add up all of the times that you have with these intrusive thoughts. If it's more than 1 hour a day spent with the thoughts or the compulsive behaviors, the hand washing and things, then that's when we would start to think of it in the context of, is that actually interfering with job, relationships and things like that. So you could have those thoughts, and a lot of us have those thoughts that pop in all the time, but it's really a disorder that merits looking and seeking for treatment if the individual themselves feels like it's a problem, or a loved one is noticing, look, these things are very difficult. In some cases, for individuals with hoarding disorder, if they have a partner, they themselves may not feel like it's a problem, but their partner is saying, look, I can't live like this. I'm going to have to get a divorce. And then that individual, it becomes a problem, right? Because they don't want to lose the relationship, but they also don't want to lose their items. So did that answer your question? Mm-hmm. Okay, good. So next one, I think right behind. Yeah. Thank you guys for being brave and asking questions. These are questions that all of you have, so yeah.
I was just wondering, for the OCD trials, your predominant method of data collection was through patients self-reporting their symptoms. So is there a more objective method of data collection than that?
Exactly. So the question was, as I described, a lot of the ways that we can tell if individuals are having intrusive thoughts or not is by asking them directly. Is there a more objective way of assessing this? And there is actually. This is embedded in our large 5-year study. We're actually doing an assessment at the molecular level to see how ketamine changes levels of glutamate and GABA. We're looking at changes in the thought control circuit. So we're asking people to engage in tasks of the ability to stop or inhibit, to really tap into that thought control circuit, as well as in the network synchrony level, we're using EEG to look at the rhythm, the biorhythm of the neurons. So just like you go to sleep and you have a certain EEG, we're examining a frequency and seeing how it disrupts it. Now, with that in hand, we may have a neural signature of what OCD is like and how it changes in the brain in order to be able to tell if a drug works and acts and actually relieves the system. So we don't yet have a link between the behaviors and what exactly is happening in the brain to shift those behaviors. As well, there's a lot of really interesting new directions that we can have with wearables and electronic devices to tap into objective measures of people checking. Great. And that.
Is there a difference between persistent procrastination and hoarding, or is it just masking? And is persistent procrastination one of the steps on the way to hoarding?
So the question was, how can we sort of think about procrastination, right? And how it relates to hoarding disorder. And procrastination is something that I see is important to hoarding disorder, but a lot of us in day-to-day life. If there's something, it's like a signal of something, like a fever, that something's wrong. You don't quite know whether you have an infection or other things that are going on. It's just a signal that there's something that's making you anxious. And that's not individual to hoarding disorder. Individuals with OCD also can be so anxious they can actually avoid different situations that might trigger. They may avoid going to public restrooms because of their fear about it. And similarly, because it's so difficult to unclutter a space, individuals may avoid that process. And so, my motto is 1 square foot at a time, and setting small goals and starting with areas of the home that are very visible. So right when you come into the home, or in your own bathroom, your vanity, if you start small and set a goal, I'm going to just declutter for 5 minutes a day, right in the morning or right in the afternoon, slowly over time you'll see that space clear, and it'll be very rewarding for you. It may be a way to kind of get a toehold or a foothold into, as opposed to thinking of the big project, just 1 square foot at a time.
I would like to know what's the difference of success rate between the CBT with the drug-administered therapies? Like, what's the advantage of your research, or asking specific, why not staying with the CBT?
Yes. Thank you for this point. So the question is, what is the efficacy of cognitive and behavioral therapy with exposure and response prevention? So for individuals that can do exposure and response prevention, it's so effective. I've seen it myself. It's, anywhere between 60 to 90% efficacy, depending on what studies. One of the advantages is that it doesn't have side effects, right? Anxiety is a side effect. And so anybody who comes to contact with our lab, we really encourage them to try that first if they haven't tried anything. Where we then go to next things is if it's too hard to do exposure and response prevention. So you can imagine if you're having a lot of fears of contamination, then having a therapy in which you're doing contamination type behaviors would cause anxiety. But what we do is we start very slowly and we work with the individual to help them understand what's the principle behind it and how overcoming their fears about these kinds of situations can really have benefit in long term. Not everybody can do it. Some people experience too much anxiety. And for some people, even when they have very good treatment, are not helped. Or individuals that are having so much symptoms and pain that may be suicidal. We start with not just exposure and response prevention, which can take a long time, but also medications in parallel. Mm-hmm. Good. Did we finish the top? Okay, I'll come back.
So I'm kind of wondering about the development of, say, OCD or hoarding, because people clearly don't go from nothing to having, full-blown OCD or whatever. What do you want to? So is it sort of? Do you see it as like a step-by-step process, or just slowly incremental? And what can people do to stop that progression?
Mm-hmm. Mm-hmm. So the question is, how does OCD develop? Is it gradual? Is it like a specific event maybe that triggers it?
And then they obsess over it, right. Or is it just like little things that happen? And is there ways, like sort of like what you're talking about, nature versus nurture? I mean, there might be a genetic component, but is there something that is it often triggered by large events, or is there a way for them to stop that slow slide? So, like if you see in a child where it's not huge, but it definitely is in their life. Let's say they don't like to wear their shoes. Do you just keep forcing them to wear shoes, and then that stops that progression, or do you just I guess I'm kind of wondering, how do you sort of try to prevent it before it can become over-consuming in their lives?
Right. So the question is, and again, I think the focus was about younger children, right, who may have difficulty putting on their shoes. You notice that maybe they're washing too much and things like that. Is there any steps that you can take to help prevent maybe obsessive-compulsive order from taking hold? And what is the impact of nature versus nurture, which is genetic in component and which is environmental in nature? All right. So what I would say is that, again, with obsessive-compulsive disorder, a lot of us, again, we'll do another little show of hands, but when we're younger, we can have these kind of intrusive thoughts and repetitive behaviors. So how many people either were careful not to step on a crack and break your mother's back, or really experience joy in aligning all your pencils for school, or any of these kinds of things that may have some traits? So raise your hand. How many people had those things when they were younger? Okay. And so, again, not all of us, a lot of us have these kinds of things, but not all of us then progress to OCD, and it's unknown what are the factors that are contributing. I can tell you that my clinical experience is that I've seen a range of all different kinds of things. So we had a patient who just out of the blue, really nothing else going on, had an intrusive thought. John made him very anxious, and he had to say to himself the word Peter to decrease that anxiety. And if he ever read any paper that had John on it, he had to mentally tell himself Peter to calm him down. There was nothing traumatic that happened to him. There was no family history of OCD. Just one day it started. I've also seen for individuals, sometimes driving home, there's a car accident or something, and afterward, then they start having a lot of thoughts about accidents and things, but that then sort of spreads to other things, like checking to make sure that they haven't harmed somebody in terms of, not that they would ever do anything, but just these intrusive thoughts that maybe they've run somebody over, having to check the news. So I think the fact that it isn't a one-size-fits-all, and there isn't evidence to support it, research evidence, suggests that that's still an unknown question. Certainly, if you're seeing behaviors that are disrupting with your child's ability to function, go to school, and things like that, it can always be helpful just to reach out for help and find out, from the wonderful programs we have here at Stanford, how to make sense of this. And what I can say is that if for individuals who are having difficulty at an early age, doing cognitive behavioral therapy and their ability to do it is so effective that if you can help a child by doing and learning these skills of challenging themselves in this time-limited way, you can really have a big impact on their trajectory. Good. So now coming down, yeah?
What was Howard Hughes's problem, and if he had OCD, didn't that contribute to his genius?
Yeah. So, I think, first of all, although I'm a psychiatrist, I can't really comment on diagnoses of other people unless it's somebody that I'm right in front of me. But certainly from the biographies and movies and things like that, that's a suggestion. The second part of your question was that part of his genius? Yeah. Is that? And Andy Warhol, who I mentioned, in the last, the end of his life, had such an affinity with collecting that he would actually gather all of his items and put them in a box. So many boxes. There's over 200 of these boxes that contain receipts, things that he collected on his travels, also collectibles like Clark Gable's shoes. And his biography in the last years of his life, it was difficult to enter his home because there were so many things amassed inside of his home. And yet, we really benefited as a society from the beauty that he captured. And so whether something that can be of great pain to people can also be of great beauty and joy is something that I enjoy thinking about.
Is there a connection between OCD and the disorder of hair pulling? I have a friend that pulls her hair out. She's almost bald, and she also has OCD.
Yes. So again, going back to the diagnostic manual that we use in psychiatry, hair pulling, also called trichotillomania, it is now within the diagnostic category of obsessive-compulsive and related disorders. And so you can have this hair pulling as its own diagnosis separate from OCD. And it has its own kind of treatments, its own kind of medications, a specific kind of therapy. If there's anybody who would like resources for that, there's national associations that focus on hair pulling, and as well, you're welcome to just email us at OCD Research, and we can put you in touch with those resources and therapies as well. Yeah. Good. I think Dan.
Your research is really interesting. I was interested whether there's a relationship with perfectionism and OCD.
Mm-hmm. Yeah, so certainly, I didn't get a chance to describe it, but in OCD, there's a lot of different types of OCD. I highlighted contamination, but there's also symmetry and exactness, having to have things perfectly aligned. There's harm. There's also taboo thoughts. So there's a lot of different kinds of thoughts within that spectrum. Perfectionism, depending on how you look at it, can be a symptom of OCD, needing to have things aligned. There's also obsessive-compulsive personality disorder, in which is thought to be individuals that are, what the expression is, you should look at the forest and not the weeds. What's the? Oh, mistake the forest for the trees? Okay, yes. But individuals with obsessive-compulsive disorder, there's a wonderful picture of like a lawn and then an individual like clipping with little tiny scissors a blade of grass to make it perfect. And that, I think, encapsulates that sort of spirit of perfectionism, but then that goes to difficulties in functioning. So I would say a lot of people are perfectionistic, and the question is, when does that go into really disrupting? Okay, so last question. I think you had your hand raised. Let's talk after, because I see a new hand up there. Yeah?
I just wanted to ask, we talk about all the issues and the problems, and I'm trying to figure out how do you, if you recognize somebody with a situation like this and that it is affecting a family, and they don't recognize it, how do you get the individual to get help?
Yes. It's a challenge. I would say it is a challenge. I've worked with families, specifically in the case of hoarding disorder. It's one of these issues that families suffer greatly. And if an individual doesn't want to part with their possessions, they have a right to their items. So the point at which it converts into something that it's a society issue is if it's increasing a fire risk or problems with hazards, or an individual doesn't have a smoke alarm or smoke detectors installed. And in those kind of situations, we work with the family, and one way that has helped is to think of it more as like a medical approach. So if there's a loved one who's just in the home, won't even answer the door or anything, we will start to leave messages. A nurse practitioner will leave messages and say, you know, hi, Mrs. So-and-so, you know, just calling to check in. Your family's concerned about you. I'm a nurse practitioner, you know, happy to answer any questions. And then they hang up the phone. They just leave a message, and so maybe the individual is hearing that. And ultimately what happens is the individual may actually fall and hurt themselves. And they might pick up the phone for somebody who's a nurse practitioner, and then they can, you know, start to build that alliance. You know, I'm happy to come over and help examine your knee, your leg. You know, please let us make inroads with you. And once the individual, who may be just shutting people out because they've heard so many times negative things about what they're doing, realizes that the family really just wants to help and is concerned about them, you can slowly start to make a difference. That nurse practitioner can be like, hey, I noticed you got some piles here that made you trip. You know, is it okay if I kind of move them to the side? Things like that. Did that answer your question?
Yes, it's just that there's more to it, but I think it's one of the things where you probably need to
I'm
talk.
happy with any of you as an open invitation to reach out to us because we want to be able to help, and different situations are different. Okay? You've been a wonderful audience. Thank you so much for your engagement.